Hello, and welcome to the Lancaster EMS presentation on CPAP for BLS. The goals and objectives of this presentation are to provide you with additional education on the anatomy and physiology of the respiratory system, to provide additional physical assessment skills, to provide a baseline education on the application of the CPAP device itself, and to ensure that all providers are comfortable with the application of CPAP and specifically with the application of the CPAP device that we have here at Lancaster EMS. So CPAP is a non-invasive procedure. It's easily applied and discontinued without much discomfort to the patient. CPAP application is useful in a variety of respiratory complaints, including pulmonary edema, COPD, and asthma. So let's take a look at the anatomy and physiology of the upper and lower airways. The components of the upper airway include the nose, the tongue, the epiglottis, the larynx, the nasopharynx, the oropharynx, and the laryngopharynx. The purpose of the structures within the upper airway are to provide protection, for example, the epiglottis closing to prevent aspiration, to provide humidification and warmth, to provide filtration and filter out any particulates in the air that we breathe, to transmit air, liquid, and solids to their terminal destination, and to serve as a common pathway for the respiratory, digestive, and vocal functions. The components of the lower airway include the trachea, the mainstem bronchi, the bronchioles, the terminal bronchioles, and the alveoli. The alveoli are grape-like clusters surrounded by a network of capillaries where oxygen exchange occurs. The purposes of the lower airways are additional filtration and removal of contaminants, as well as the transmission of air and oxygen to the terminal airways. So how does CPAP work on the lungs? Well, CPAP has a variety of effects. First of all, it maintains a constant pressure within the patient's airways, even after exhalation. The device that we utilize at Lancaster EMS provides a constant pressure of 10 centimeters of water pressure. CPAP also opens bronchioles and alveoli. It prevents the collapse of bronchioles and alveoli, and redistributes any fluid that may be in the alveoli. All of this improves gas exchange, relieves respiratory distress, and helps buy time to get the patient to definitive care or an ALS intercept. So to help you better understand how CPAP works, I've put together a little demonstration. Here we have a bag valve mask with a balloon attached. The balloon represents the alveoli. This device currently has no device attached for end expiratory pressure and therefore represents a person breathing without the aid of CPAP. If we take a breath, we see that the alveoli inflates. When we exhale, in some patients, those alveoli will collapse. In other patients, those alveoli may be filled with fluid. Either of those two situations impair gas exchange at the alveolar level. If we add this device called a PEEP valve, which approximates a CPAP, and then take a breath, we'll see that as we exhale, pressure within the alveoli is maintained. This allows additional oxygen exchange to occur. There are some things that CPAP can and cannot do. CPAP does not affect the underlying disease process. If we were to remove a patient from CPAP, without additional treatment, they would quickly return to their underlying condition. CPAP does reduce the need for intubation and reduces the length of hospital stays. And because CPAP reduces the need for intubation, it also reduces the risk of intubation-related complications, such as laryngeal edema, laryngospasm, vocal cord injury, and infections. So let's review some signs and symptoms of respiratory distress. Patients presenting with respiratory complaints may have increased work of breathing, retractions and accessory muscle use, inadequate chest expansion, diminished, absent, or noisy breath sounds. They may be anxious or restless. In adults, respiratory rates greater than 25 breaths per minute may be indicative of respiratory distress. They may have oxygen saturations less than 90%, and they may have pale, cool, and cyanotic skin. So now let's discuss how we assess respiratory patients. To begin with, we're going to want to assess the patient's mental status. Are they awake and alert? Are they oriented? And if so, how well are they oriented? One of the most worrisome signs of hypoxia is a change in mental status. And this change in mental status often indicates a patient going from a more stable condition to an unstable condition. Next, we're going to look at the ABCs. Is the patient able to maintain an open airway? Are they breathing? If they are breathing, is it labored? Does that patient have distal pulses? Is there any sort of circulation issues going on with this patient? Is the patient cyanotic? So next, we're going to assess breath sounds. We're going to listen to all areas of the lungs, both posterior and anterior. And we always want to compare left side to right side. So, for example, if we're listening to the right upper lobe on the posterior side, we're going to compare that to the left upper lobe on the posterior side before advancing to the next lobe. Another condition which may require the use of CPAP is COPD. We'll also throw patients with asthma into the same category of chronic obstructive pulmonary disease. Patients with COPD exacerbation may have tachypnea or rapid breathing, increased work of breathing evidenced by accessory muscle usage. They may have audible expiratory wheezing or maybe expiratory wheezing that's only heard on auscultation. They may also have diminished lung sounds with very little evidence of air movement. Patients with COPD exacerbation often present in a tripod position. They may have cyanosis, and again, as with most patients experiencing some level of respiratory distress, they may experience some anxiety. If they've been working quite hard to breathe, they also may be fatigued. They may have tachycardia and may display flaring of the nostrils, pursed-lipped breathing, or retractions. And when trying to converse with a patient with COPD exacerbation, they may have the inability to speak in complete sentences. So let's discuss some of the indications for CPAP. These indications are referenced in BLS protocol number 421. First of all, the patient must be awake and able to follow commands. They need to be at least 14 years of age, unless ordered by medical command, and they must physically be able to fit the CPAP mask. They also have to have the ability to maintain an open airway. Additionally, patients must exhibit 2 or more of the following signs and symptoms: a respiratory rate that's greater than 25 breaths per minute, a pulse oximetry reading of less than 90% at any time, and or the use of accessory muscles during respirations. Contraindications for CPAP include patients with altered mental status or those that are unable to follow commands, a patient who is in respiratory arrest or is apneic because CPAP does not provide respirations, only additional airway pressure, patients that have a respiratory rate less than 10 breaths per minute or cannot maintain an open airway, patients with chest trauma or suspected pneumothorax, a patient who has a tracheostomy, or a patient who is actively vomiting or has upper GI bleeding. So there are a few things you should expect anytime you apply CPAP to a patient. First of all, the patient may be anxious. Also, they may become combative. These conditions may be because of the hypoxia that the patient is experiencing, or simply that the device is unfamiliar or maybe a little claustrophobic. So expect that you're going to need to spend a little time coaching the patient on breathing with the device in place before they become comfortable with it. There are some additional considerations to keep in mind anytime CPAP is utilized. To begin with, the pre-hospital CPAP devices rapidly deplete oxygen cylinders. Therefore, it's necessary to always have a backup supply of oxygen immediately available. Also, ALS should be requested if CPAP is used. As we mentioned in a previous slide, CPAP does not correct the underlying condition. However, ALS providers may have additional treatments which may benefit the patient. We also should notify the hospital anytime we use CPAP. The hospitals need time to prepare for the patient's arrival and gather the necessary adapters and hospital CPAP machines for transition from pre-hospital to hospital CPAP. We should also monitor for gastric distension from the additional pressure in the airway. CPAP can be used with patients with a DNR. CPAP is not considered ventilation and does not require intubation, and therefore it may be applicable on patients with DNRs or advanced directives. And then finally, vital signs need to be documented every 5 minutes on any patient with which CPAP is being used. So now that you have a better understanding of how CPAP works and the criteria for pre-hospital application of CPAP, let's take a look at this Pulmodyne video on the O2 Max CPAP system. This is the CPAP system currently utilized at Lancaster EMS. It is fitted with a fixed PEEP valve that's set for 10 centimeters of water pressure as indicated in the PA BLS protocols.
The O2 Max generator is a fixed-flow Venturi device that uses an oxygen supply in conjunction with entrained air to generate an output flow. The O2 Max generator uses a 50 psi disc port oxygen supply and can generate flows up to 140 liters per minute and fractional inspired oxygen at approximately 30%. The preset PEEP valves, which are snapped onto the housing end of the circuit, are used to maintain preset positive pressure at flow rates from 60 to 140 liters per minute. The O2 Max system includes a fixed flow generator with filter, a 72-inch corrugated anti-asphyxia circuit, the O2 CPAP valve, mask with head strap, and a 30mm adapter to be used with prepackaged nebulizer kits. Setup for the O2 Max generator is simple. First, connect the fixed flow generator to a disc-fitted power takeoff on the oxygen tank regulator. Once flow has started, take and expand the corrugated circuit. Now take the O2 CPAP valve and while holding the bottom of the valve with one hand, rotate the flow setting dial with the other hand until the indicator is lined up with the desired rate per your system's protocols. Now take the corrugated circuit and connect it to the mask. Once connected, try and coach the patient to take the mask and hold it to their face. This helps reduce patient anxiety and improves patient compliance during their treatment. Fit the mask head straps accordingly over the patient's head and clip the bottom straps to the bottom of the mask. The top and bottom straps can be adjusted using the Velcro tabs. The O2 Max mask is designed to be fitted loosely yet still deliver proper pressure without leakage. Fitting the mask too tight could cause crinkling of the mask, resulting in potential leakage as well as discomfort to the patient. The O2 Max mask also incorporates an adjustable forehead pad that can further improve patient comfort as well as a proper mask seal. Included with the O2 Max system is a 30mm nebulizer adapter. The adapter allows the connection of a nebulizer T-section, which provides a nebulizer system to be mounted between the mask and corrugated circuit. During operation of the O2 Max system, it is important to check the following on a regular basis. Ensure that there are no leaks at the patient connection. Ensure that the generator is supplying adequate flow to meet patient demand. Monitor the patient's arterial blood oxygen saturation as well as end-tidal CO2. Monitor the patient for signs of dehydration and discomfort in the upper airways. Always follow your local protocols when using the Pulmodyne O2 Max system.
This concludes the Lancaster EMS presentation on BLS CPAP. Thank you and have a safe day.